So as we continue along looking at a mix of anatomy and physiology, depending on where we are in the body, but mostly centering it all around motion and making the motions the central part of our network of meaning or our semantic network, we're looking at lumbar flexion here. Now, there's going to be a lot of similarities as far as the how lumbar flexion is generated between lumbar flexion and thoracic vertebral flexion. And that's because both of them would actually better be described as torso flexion. So when you're assessing torso flexion, you may note issues with either the generation of torso flexion within the lumbar or thoracic regions, but realistically, because it's an osteopathic lens that we're applying here, what you would actually notice is issues with thoracic or lumbar extension. So to prove that something is flexed, because osteopathic practitioners name things for what they like to do, you would actually have to extend it. So either way, what we're really talking about broadly is thoracic or torso flexion rather, and we would identify it within a thoracic or lumbar region based on testing extension. Now that said, we're obviously looking at what actively generates lumbar flexion here, which are torso flexors. So we look at our objectives, and our main objectives is a specific discussion of what lumbar flexion is, planes and axes. Now this is obviously getting repetitive and it's completely on purpose, but we will talk about it. We'll have a general discussion of the muscles that flex the lumbar column, a general discussion of the nerves that supply those muscles that generate lumbar flexion, general discussion of the vascular supply. So there's going to be a lot of overlap here between thoracic flexion as well as thoracic side bending and rotation. So you would have already seen quite a bit of this. However, it bears repeating on purpose. We will then have a very specific or superficial rather discussion of the foregut, the liver, the pancreas, the spleen with associated neurovascular structures, which is essentially the celiac artery and the celiac trunk and the celiac ganglia and the greater splanchnic nerve. So we'll get to all of those things as we roll through it. And we'll also have a very, very superficial discussion with each one of those structures as far as some of their functions. But again, it will be very superficial. Then we'll have a general discussion of the areas to assess and treat should lumbar flexion issues be suspected or reported. Now, again, because this is more broadly appropriately termed torso flexion, a lot of that will then be repetitive with respect to the thoracic flexion and thoracic side bending and rotation modules or presentations. So what we look at the planes first. So our quick run of the planes, the sagittal plane is 50% cut left and right of the body. The horizontal or transverse plane, 50% cut top to bottom of the body. Frontal or coronal plane, 50% cut back to front, or kind of front and back half of the body. Axes are perpendicular to planes. So the sagittal plane, perpendicular to that is a transverse or horizontal axis. The horizontal plane or transverse plane is a vertical axis, and the frontal plane is an AP or PA axis. So in the case of flexion, it is forward bending within the sagittal plane. So because it's essentially forward bending, it would more so be termed a rotation because it has an axis, but we don't use the term rotation for it because rotation is the common term for movement in the horizontal or transverse plane. But it is forward bending in the sagittal plane on a transverse or horizontal axis. Now, if we're talking about lumbar flexion, primarily what we're talking about is the muscles that will flex the torso, which would be primarily your rectus abdominis, your external oblique, and your internal oblique when all of them are functioning in a united way or a bilateral fashion. Transverse abdominis, because the fiber directions are essentially perpendicular to the rectus abdominis, that's primarily aimed at pressurizing the contents of the abdomen, so it doesn't necessarily contribute to movement here, but primarily for lumbar flexion, you're looking at the abdominal muscles minus TVA. Now that said, there's an obvious, it's almost like a big flashing light with respect to a particular muscle that is on the anterior surface of the vertebral column in the lumbar region in the form of the psoas, and many people will have a lot of discussions about it. I've heard many discussions in personal experience about how important this muscle is. However, when you actually dig into literature that's available discussing the psoas, what you will find is it is very rarely actually termed a lumbar flexor or even a lumbar side bender or rotator. Its primary effect, especially in common movement on the lumbar column, would be stabilization. So what you will often see is as one leg goes anterior or one leg goes into hip flexion, because the psoas is definitely hip flexor, what happens is the opposite psoas immediately turns on to more or less stabilize the lumbar column. The One caveat to that is you will see some agreement in some sources, or at least quite a few sources, that before I get into the psoas a little bit, I'll finish this off with the psoas and I'll talk about it again just because I've jumped ahead of myself. But the common thing in many sources is that the psoas will contribute to trunk flexion when somebody is in supine, right? So if somebody is flat on their back or on their back with their hips flexed, the psoas can then contribute to trunk flexion, not necessarily lumbar flexion, so trunk or torso flexion. But as far as the nerves for the abdominal musculature, because we want to touch on that, the vast majority of the abdominal musculature is supplied by the intercostal nerve, so the anterior primary rami coming out between or within the intercostal space, superior in the intercostal groove, but it's vein, artery, nerve. So the nerve is inferior to the artery in this case. So it's going to travel around and supply the body wall. So it will supply the intercostal musculature, as well as then descend to supply the vast majority of the abdominal musculature. Now, the one caveat to that is the internal oblique does seem to get some innervation from the upper lumbar region, so L1, L2-ish, depending on the source that you're going to read or encounter. Now, as far as the vascular supply to the abdominal musculature, we've seen this again in previous presentations, but what we're talking about is the epigastric circulation, so the superior portion coming off of the subclavian artery, descending through the internal thoracic or internal mammary artery, and then piercing through, becoming the superior epigastric artery. And then there will be branches thereof. You will also have off of the iliac circulation, the inferior hypogastric arteries, and then you will get some supply primarily to internal intercostal from lumbar arteries, and those lumbar arteries are going to, in some cases, come directly off of the abdominal aorta. So it's a very, very confusing, or sorry, a very broad circulatory pathway. So if you're thinking about the circulatory pathway that would be interrupted with respect to lumbar flexion, you're essentially thinking about the whole torso, which is again why we make the case that paying attention to the motion will allow you to respond more accurately to the situation at hand, as opposed to thinking about all of these anatomical structures. So when you're treating, it's more important to pay attention to the motion, because the anatomy is actually quite diffuse that would feed blood to it, at least if you were thinking about blood. Even if you were thinking about nerves, the neural tone is very diffuse. Again, so it becomes essentially the whole torso, and then you can even go lower down. You can start to think of the hip. If the hip is in some way affecting the psoas, affecting the lumbar column, possibly affecting lumbar circulation, or iliac circulation rather. So you have a very, very broad area to think about as far as the anatomy is concerned. Whereas if you just identify the motion problem, you can be much more accurate in your approach to the patient. Now, as I had noted, the psoas with respect to torso flexion or trunk flexion or vertebral flexion. So you can see in the image there, you actually have the psoas minor identified. So the psoas minor is the most medial structure, or the structure that is just lateral to what is yellow, which is the sympathetic chain ganglia on the midline, and you see all the connective tissue on the midline in the form of the anterior longitudinal ligament. So then what you have is a sympathetic chain ganglia, and then you have psoas minor, which is not necessarily present in every individual. Then slightly lateral to that, you have psoas major, which is pierced by some of the lumbar plexus. So some of the nerves will go behind it, some of the nerves will go inferior to it. If you pull psoas major off there, then what you would also see is some fibers off of the lumbar plexus, essentially piercing through the attachment points of the psoas. So you'd see that. Then the psoas, as I already noted, in supine, it will contribute to torso or trunk flexion. However, in a standing position or any other position, it doesn't really necessarily do that. It will more so contribute to hip flexion, because that's its main job. Now, as far as the midgut is concerned, so we need to look at the splanchnic system, or the thoracic splanchnic nerves. So the thoracic splanchnic nerves are essentially coming off of T5 to T12, right? So T5 to T9, very generally speaking, would be considered the fibers that would contribute to the greater splanchnic nerve. Then T10 and T11 is the lesser splanchnic nerve, and T12 usually, I believe, is the fibers for the least splanchnic nerve. Said essentially what it is you have fibers coming off of multiple essentially spinal segments, as far as out of really more so the sympathetic chain ganglia. So you'll have postganglionic fibers coming out, and then they will merge. So on the view on the left, you see essentially an artist's rendering, and then the view on the right, you can see how they've dyed that nerve, or they've changed the color on it, or all that neural tissue. So you can see, so it's the stellate ganglia, so SG is the stellate ganglia, and if you look down, thoracic ganglia 2, thoracic ganglia 3, so you're getting mixing of the postganglionic fibers from T5 to T9, leading to what would be considered the greater splanchnic nerve, because it mixes in. That then descends through the diaphragm with the abdominal aorta, so the descending aorta, the thoracic aorta, as it goes through around the diaphragm at the aortic hiatus, which is around T12. These fibers will wrap around the abdominal aorta and continue on with it before synapsing with another ganglia. And in this case, it is the celiac ganglia, which is actually paired, whereas some of the other ganglia on the aorta or the abdominal aorta are not necessarily paired. Some are, some aren't. But what you then see is the celiac artery. So with respect to the celiac artery is the first unpaired artery coming off of the abdominal aorta, and it supplies the foregut. So the foregut essentially being the stomach, or the final portion of the esophagus, the stomach, and the first half of the duodenum before the major duodenal papilla, but also because of the celiac artery supplying the liver, the bile duct, or sorry, the gallbladder rather, the liver, the gallbladder, the stomach, the pancreas, and the spleen, those structures would generally be considered related. So it's not necessarily that they're foregut, but they are related off of the celiac artery. So on the left, what you can see is a CT scan of the celiac trunk or the celiac artery and how it's going to go out and fill. If you look slightly lower down, you can see the renal arteries as they go to the kidney, because you can kind of see the shadow of the kidney in there. But you see how the first thing that pops off kind of goes forward and then does all the snaking, and that is going to the organ. So the one that is going to the left, the left is going towards the stomach, the spleen, the pancreas, and the first half of the duodenum, the stuff that's going to the right, is going to the gallbladder and the liver. And then on the right side, you get a general artist rendering of how that goes. So it's kind of comes down and then just starts to shoot off immediately, which is somewhat mirrored in the CT scan. The portal system, so with respect to the foregut, and really the foregut, the midgut, and the hindgut, all of that circulation doesn't go directly to the inferior vena cava. It goes through what's called the portal system. So you will have the inferior mesenteric artery coming off, or vein, the inferior mesenteric vein coming off of the hindgut, which was the distal third of the colon, the transverse colon, the descending colon, the sigmoid, and the rectum. That goes more or less up, blends in or empties into the splenic vein. The splenic vein comes across, so it comes from the spleen, will take blood from the stomach, the pancreas, obviously the hindgut in the last portions of the colon, and the superior mesenteric artery is going to take from the first 2/3 of the transverse colon, the ascending colon, and all of the small intestine. And that is, that is more or less going to empty into the splenic vein, and that's where they become the portal vein. The portal vein goes into the liver. The liver will filter all of that blood, do whatever it needs to do, and then put it into, so it's the hepatic veins will dump into the inferior vena cava rather, and then that will go back towards the heart in the right atrium. So the portal system is taking blood from pretty much all of the abdominal organs, at least with respect to the gut. So the foregut, the hindgut, so the foregut, midgut, and hindgut. The kidneys are an exception to this because the kidneys go directly into the inferior vena cava. Now, as far as the ganglia are concerned, so we talked about the greater splanchnic nerve, T5 to T9, essentially blending into one, following the aorta through the aortic hiatus. And then you can see the top ganglia, which is paired on either side of the celiac trunk. What happens is then there's the greater splanchnic nerve is postganglionic to the sympathetic chain ganglia, but it's preganglionic to the celiac ganglia. The celiac ganglia then puts out postganglionic fibers to the organs. So the liver, the gallbladder, the stomach, the pancreas, and the spleen, and the first portion of the duodenum. So those fibers all follow the celiac arteries, or the arteries that branch off of the celiac trunk, and then they are also going to generate plexi with respect to mixing with the vagus nerve. So the vagus nerve will provide parasympathetic tone, whereas these postganglionic fibers off of the celiac ganglia will provide the sympathetic tone to those structures. And you can also see the other aortic ganglia that are going to follow the rest of the arteries coming off of the aorta, which we'll discuss in other portions, looking at the lumbar motions. The foregut, as we noted, the celiac axis or celiac trunk, giving off branches to the liver, the gallbladder, the pancreas, the first half of the duodenum, the stomach, and the spleen. As far as the functions, liver obviously has many, many functions. You'll see different numbers associated with it, but the liver has many. So we can very superficially say broadly digestion, filtration of blood, and also blood pressure regulation to some degree, as well as metabolism. The gallbladder, the storage, and so one of the digestive functions anyways of the liver is to generate bile. The gallbladder is storage and concentration of bile and secretion of bile into the second half of the duodenum after the major duodenal papilla, as the pancreatic duct and the common bile duct will enter into the duodenum at that point. So that is fat digestion, because bile is basically responsible for the digestion of fat. Now the stomach is going to perform digestive and at least some absorption, or digestive function, some absorption function. So digestion in the mechanical churning of the food bolus, as well as chemical breakdown, so carbohydrate breakdown, and some early breakdown of proteins to smaller chunks of, I believe it's polypeptides or polyamines. I'm sure I'm messing that term up, but it takes it from a large protein to a smaller portion, which will then be further digested once it gets past the major duodenal papilla, and the pancreas is providing some more protein digestion chemically with respect to pancreatic juice, or some of the contents of pancreatic juice. So the pancreas has the exocrine function. So exocrine is essentially outside of the body. It's function outside of the body. The gut tube is considered by some to always be outside of the body. So basically mouth to esophagus, so mouth to really larynx, then the pharynx, or sorry, mouth to pharynx, pharynx at larynx, splitting, then the gut tube, so the esophagus, the stomach, the duodenum, the jejunum, the ileum, the colon the whole way, the sigmoid, the rectum, those are all considered exocrine. So it's because it all folds, it's never really necessarily something that is directly inside of the body. So there's an argument for that. So the exocrine function is essentially your digestion of protein, carbs, and acid-base balance of the food, right? So the food is or the chyme rather, is very acidic as it leaves the stomach. The pancreatic juice does have bicarbonate, which will neutralize that, kind of bring it back to the middle. And then the pancreas also has an endocrine function, so in the form of insulin. So insulin is a transport molecule, obviously does do quite a bit for blood sugar. Glucagon, which is essentially the balance. So insulin will more or less pull sugar out of the blood. Glucagon will put sugar into the blood, or signal. Somatostatin is essentially an overarching signal for growth hormone and the growth hormone cascade. So that's the endocrine function. Now that doesn't go into the gut, that goes into the blood. So with respect to the circulatory system within the pancreas, the signaling for the endocrine function will go into the blood. The exocrine goes into the gut tube, the endocrine goes into blood. Now the first half of the duodenum, so again, we're talking about the foregut, that's really just transit of chyme, because there's really not a ton of absorption that happens there. The food is still very acidic, and once it hits the major duodenal papilla, more digestion will occur, because the pancreatic juice and bile will enter and then continue the digestive process. As far as areas of consideration for assessment and treatment, in the case of lumbar flexion, or if you have issues with lumbar flexion, remembering that flexing forward doesn't show you a flexion issue. extending shows you if something will not extend, therefore it is flexed, at least in the osteopathic lexicon or osteopathic terminology. So if you're going to be considering attempting to interface with a lumbar flexion, you're going to consider the abdominal wall because of the abdominal musculature. It's very rare that you're actually going to treat the abdominal wall for a lumbar flexion, but it means that you can consider it. Usually the treatment is going to be somewhat long lever, so you're going to put, more or less pull the torso backwards, or the a lower limb backwards, posterior to the body, in order to interface with this. But you're going to think about the lumbar vertebrae themselves, so you can be short lever on the lumbar vertebrae. You're going to think about the ribs because of the abdominal musculature. The T-spine, broadly speaking, so you may actually use the T-spine as leverage, but you might also want to investigate it for related issues or larger motion issues. As far as what to stay away from, and also with respect, please excuse me because it's not typed here, but with respect to considering dealing with lumbar flexion or identifying lumbar flexion or treating lumbar flexion, you will also want to consider the hips, because the hips are obviously attached directly to the lumbar column through the psoas. So there is some degree to which it may have influence. And even if it doesn't, what they may allow for is good leverage or a connected finding. So you would also consider the hips here. Now, as far as what to stay away from, known or suspected fractures within the lumbar column, tears, you will be more likely to have tears in muscles that would interface with lumbar flexion. So you may have a tear in the psoas, not the most common, but possible tears in the abdominal wall, such obviously hernias, but there may also be larger tears in the abdominal wall, depending on how athletic somebody is. If you identify any rebound tenderness, so if you push on the abdomen for whatever reason and it is not sore, but when you let go, it's sore, that is a very, very superficial, immediate red flag for abdominal pathology or pathology of abdominal viscera. That is a big no-go. So again, fractures or tears, fractures in the lumbar vertebrae themselves, fractures possibly in the pelvis, that would all be indicated by recent trauma. Rebound tenderness, you're going to stay away from. Tears, you're going to stay away from, because if you move a tear, you're likely to disrupt that tissue more. Now, an abdominal aneurysm or an abdominal aortic aneurysm is much easier to identify than a thoracic aortic aneurysm. So if a patient is in supine, even less lean patients, so lean patients, it's fairly easy to see. You actually will in lean patients see some bounding of the abdominal wall when they're in supine. It shouldn't be gigantic, it shouldn't be large, it shouldn't just be, you glance in the region of the abdomen and you see a large bound. If you see a large bound, then that's something to be investigated. In people who have more body fat, then it is obviously a little bit more obscure, but it is still often visible. So even in people with more body fat, you can see the abdominal wall bounding or moving essentially anterior, posterior when they're just laying at rest. That is a superficial signal that there's a possibility of an abdominal aortic aneurysm. If the patient does not know that that's the case, then that would be something to refer for further investigation, because if you put excess pressure through that weakened abdominal aortic wall, it's possible that you can contribute to further weakening of it, or possibly under the absolutely wrong circumstances, it's possible that it will dissect, and that would be a very, very terrible day. So those are our general considerations with lumbar flexion.